I'd like to start off the introductions. Welcome to AWE Endoscopy Cafe, expert conversations. And I'd like to introduce Dr. Sonia Riker, and she's the original co-founder as well as I'm Phoenix Wynn for the AWE, which is Association of Women Endoscopists. We collaborate on these cafe endoscopy with WIGNAP. And on here we have Dr. Nantali Pazawazdi as the leader of WIGNAP, which is our Asian counterpart. We've been doing this for the past year and we've had really good success. And it's meant to be a more casual conversation, case discussion, where we have a cup of coffee or a glass of wine, whichever one you prefer. I think Sonia has her tea ready. I'd like to introduce our speakers. I'd like to start with Dr. Kenneth Chang, who is, of course, does not need an introduction. He's so well known. He's really an international, well-known person, and he's recently joined our institution. And when you hear things in medicine like PPG, the name Dr. Chang is associated, and it's for me, a household name, and we're very proud to have Dr. Chang here with us today. Dr. Chang is currently the Executive Medical Director at Hoag Hospital for our Digestive Health Institute. Hoag is in Newport Beach, California. And again, I will probably have to spend an hour to introduce him, but thank you, Dr. Chang, for being here. Our second guest speaker I'd like to introduce is Dr. Sai Jirapanayo. I hope I said your name correctly. She goes by Sai. Her first name is a little bit more challenging. And Dr. Sai J is an advanced endoscopist and bariatric endoscopist at Brigham and Women Hospital and Director of Bariatric Endoscopy Fellowship. And in the areas of endoscopic management of obesity and metabolic diseases, including MASLD, which used to be NASLD or something of that sort. The names have changed. She has published over 120 peer-reviewed articles on this topic, is a national and international speaker. Again, thank you, Dr. Sai, for being here today. We'll start off with our first presenter or case, if I may. Sonia, do you want to say something to welcome everyone?
But thank you so much for joining us. We get, well, actually, Phoenix gets this mad ideas, but this particular one, I think Nantali and I have to take the credit for. But I think it turned out to be not bad. So thank you so much, and we really appreciate everybody being here today. Phoenix, would you like to introduce Ravi?
Yes.
To start?
So we'll do our first case today is going to be presented by Dr. Ravi Kankodia. Ravi's our therapeutic endoscopist at Hoag. He's very swift with the scope. He has a passion in liver disease and endohepatology, and he has a wonderful case for us today. Dr. Kankodia, you're on.
Thank you. Thank you for allowing me to present today. Thank you for the introduction, Phoenix. As Phoenix mentioned, I'm one of the interventionalists at Hoag and her colleague. I'll go ahead and get started with our case. So so we have a 65-year-old woman with well-controlled diabetes, type 2, BMI of 36, who's referred by her bariatric surgeon to hepatology for an evaluation, namely because she's found to have fatty liver, findings of fatty liver on transabdominal ultrasound and some abnormal liver tests. Briefly, the rest of her history is notable for a lack of substance abuse. She does have some metabolic risk factors in her family. She's on atorvastatin and metformin, mainly for her diabetes, and her exam is otherwise unremarkable besides her central obesity. Her labs on presentation to the hepatologist's office: normal CBC, platelets are low normal at 160. Her BMP is normal, and her liver panel shows an AST of 25, an ALT 30. It's been bouncing around in the 30 to 40 range, a normal alk phos, and a normal total bilirubin. The hepatologist did a couple non-invasive tests, one being the FIB4. As you see on screen right, is a amalgamation of the patient's age, AST, the platelet count, and the ALT. The FIB4 was calculated at 1.85. This sort of puts her at an intermediate risk for fibrosis. And then she also had a fibroscan done in the office that is also at an intermediate risk at 9.9. She was then referred to advanced endoscopy for further one-stop shop type of endohepatology evaluation. Should I pause here?
No, I think this is great. I'd like to start off maybe with Dr. Cheng, and if you, as an endosonographer, we want to have you walk us through as we put the echo endoscope in. What are you looking for? What do you do in assessment of these patients?
Yeah, sure. So we always start with an endoscopy to look for any sequelae of portal hypertension, varices, portal hypertensive gastropathy. So we would do that first, just a forward view gastroscope. Then we would, which is here. And then we would look on EUS. First, we look on imaging to see what the echotexture is of the liver, where there are signs of fatty infiltrate. Then we're looking for signs of possible advanced fibrosis or cirrhosis, looking at the surface of the liver, looking at the liver edge. And then we'd like to do a manual palpation of the liver. We can talk about that in a minute. And then after that, I also look for, obviously, ascites. Then after that, we turn on shear wave elastography and evaluate right lobe, left lobe, and spleen. And then depending on the findings, we could move to either EUS portal pressure gradient measurement and or EUS liver biopsy, depending on the clinical scenario.
Dr. Sai, would you do a gallbladder bile duct evaluation? Do you look around adjacent to the esophagus for paraesophageal varices? What, besides the liver, do you look at, or do you not look at? Do you look at the pancreas? And sometimes we find pancreatic cysts and we're like, oh gosh, I shouldn't have looked.
I mean, great question, Phoenix. I mean, to be honest, I usually go in, I do endohepatology workup, and I learn from Dr. Ken Chang and also Marvin Yu at Brigham. So I usually focus on the hepatology piece. So I don't routinely do the pancreatic workup during part of that exam. In terms of esophageal varices, I mean, definitely look at it on endoscopy. I normally typically don't look at it on EUS unless you kind of find something concerning during the typical endohepatology workup that Dr. Chan mentioned.
Very good. Thank you. Dr. Concodia, would you like to show us what you're seeing?
Yeah, so let me go back. So just as an aside, transabdominal ultrasound just showed a hyperechoic liver consistent with fatty infiltration. Upper endoscopy was relatively unremarkable, esophagus without varices, some glycogenic acanthosis, but nothing really there. The fundus looked fine, no gastric varices, no PHG. The rest of the stomach mucosa looked fairly normal. And then the duodenum also looked normal as well, no ampullary issues. EUS was then performed. Similar findings as with transabdominal ultrasound for this patient. No collaterals were noted. Again, the hyperechoic appearance of the liver, relatively smooth, although I don't think this picture does that justice. And then the bile duct was notably just 3 to 4 millimeters in size, no gallbladder stones, and then the pancreas at the time just was mildly lobular, nothing else really.
Does that liver edge looks a little blunt, or is it just my imagination?
Yeah, it looks a little blunt to me. Maybe not the best, not my intention, but yeah. So selecting that image at least. Okay, and so during the same session, per discussion with the hepatologist, PPG was done. You can pause here to kind of go over technique or questions related to PPG.
Yeah, Dr. Chang, can you review for us the history and how we got to where we are, comparison with IR techniques, and how we arrived to this EUS technique?
You got an hour? No. Yeah, so we understood that the best prognostic factor for liver disease, period, is the gradient, the portal pressure gradient, which is done by IR, where they measure the free hepatic vein pressure and the wedge hepatic vein pressure, and that gives you the gradient. But we know that that test is almost never used or very seldomly used for pure diagnostic. It's used before and after a TIPS procedure, but for pure diagnostics, very few people with liver disease will ever get that. And so there was a real need to be able to offer that. In addition, there was the limitation because the wedge hepatic vein pressure was an indirect reflection of the portal vein pressure, not a direct portal vein measurement. And because in endosonography, we always see the portal vein. And so, we began to work in the animal lab to work on various techniques, needles, various pressure gauges, wire gauges, et cetera, to be able to measure the portal vein pressure directly. And so we finally landed with this technique, which takes the smallest needle, 25 gauge, and we attach it to a non-compressible tubing that's attached to a pressure monitor, gauge monitor, and then that is attached to the 25 gauge needle, and then we can advance the needle just like we would do FNA with the needle primed, and once the needle enters into the vessel of interest, we flush the tip to get rid of any air bubbles, and then we let the pressure equilibrate, and then we get a very, very precise number, which is the pressure in the vessel. So typically we'll measure the hepatic vein side first. We usually hit either the middle hepatic vein or the left hepatic vein and measure it 3 times. And then we turn our attention to the portal vein, and usually it's the left portal vein, the umbilical portion of the left portal vein. And we put the needle there and measure it 3 times. And then we average those 2 vessels and subtract the difference and get the portal systemic pressure gradient. And we've done many studies correlating that with IR, HVPG, and it's the correlation is almost perfect. So we're finding that because EUS is very, very accessible and available, and there are many more endosonographers out there with interest, that people are turning towards this to assess liver disease more and more. And so it's becoming more and more mainstream. And you can see here the pulse wave is nicely shown. It has 4 phases, and that's typical of either IVC or any of the 3 hepatic veins. And then way on the right is the pulse wave of the portal vein, which is a monotonous holosystolic diastolic venous hum. So we first use pulse wave Doppler to make sure that we're targeting the correct vessel, and then we advance the needle in.
Very nice. Dr. Kankodia, would you like to review the results? And then we'll have Dr. Sai go over the technical challenges for performing this technique.
Yeah, so I have results listed here. So the middle hepatic vein was punctured and measured at 8 millimeters mercury, and the left portal vein was punctured and we had a value of 14. The gradient came out to 6.
Dr. Sai, remember you taught us in the pig, the lazy left, and we've taken that back and we've adopted all your techniques. Maybe can you review with us the technical challenges of performing PPG and any tricks and tips and how to do this?
Yeah, so I mean, from a technical standpoint, so essentially, I usually have the patient intubated. So I perform this procedure under general anesthesia. I know that some endoscopists do this under MAC. So I think either option is okay. But to me, I prefer having patient lie quite still, especially because I usually combine PPG with liver biopsy. In terms of positioning, I usually do lazy left and then make sure that we have the laser and then make sure that that laser is kind of like at the mid sternum area. So that's where you're going to put the manometer. In terms of challenges, for certain circumstances, I found that for patients who are very cirrhotic, then the vessels can become quite small. So I think that will become more challenging compared to patients who have early fibrosis stage. And then this is much less frequent. I ran into this situation probably 2 out of, I've done probably about 150 now, 2 cases where portal vein was really, really deep. So when you try to access the left umbilical portion of the portal vein, the needle might not be able to get access in from the left or from the stomach side. And then if that happens, then I would go into the duodenum and then look up and then try to access the portal vein from the duodenal side.
What do you guys suggest in a situation where sometimes it's really challenging to get the, well, probably very easy for you guys, but sometimes challenging for me to get the angle for the middle hepatic vein? It seems to be the needle comes out parallel, and even trying to get the left may be too small. What do you suggest in this situation?
Yes, Sonia, if there are times when technically it is, difficult to hit any of the 3, and this is considered off-label, but I just hit the IVC, and we've done about 50 paired exams, IVC plus middle or IVC plus left, and the difference is 0 to 1 millimeter of mercury, and the IVC is easy to hit almost always.
It's a big target, hard to miss that.
Hard to miss, yeah.
Any particular like, because we always, when we try to go for the vessels, we try to have some liver in between. Any tips on how you do that with IVC?
Yeah, just to, again, try to make sure that there is at least a little bit of liver. It could be a ½ centimeter sliver of liver. That's fine, because that's all you need to tamponade your puncture site. So for IVC, typically you go through cut 8 to get to it. But yeah, just anywhere. And the other thing is you want to hit the branches of the hepatic vein within 2 centimeters of their insertion into IVC. You don't want to go 5 centimeters out where the vessel is small, and you can get false levels if you go too far out.
I see.
And
Any,
usually I want the 3 numbers, like the 3 hepatic venous pressure or portal venous pressure, to be within 2 millimeter mercury from one another. If you don't get them within 3, then I would start over and make sure you get 3 consecutive numbers that are within 2 millimeter mercury.
That's a great.
Just one quick question. I know we have to move on. Any instructions that you give to your anesthesiologist if you do general anesthesia? That anything they need to avoid during the measurement when you're actually doing the measurement?
Yeah, it is very important to communicate with the team that, and you tell the anesthesiologist, okay, I'm going to take the first measurement, and that signals to him or her not to give any vasoconstrictor or vasodilators or anything in between your measurements, because then that can mess up your gradient.
Okay, Dr. Kinkodia, did you do a liver biopsy next?
Of course. Right, so we did a liver biopsy, and the pathologist read it. It didn't have a specimen from this case, but macrovesicular steatosis, some rare fibrosis, but still forming septae. They read it as a F2 Medivir score.
So we'll start with Dr. Tsai for this question. Do you do both left and right? What is your preferred size of needle? A little bit on the technique.
Yeah, so I use a 19 gauge FNB needle, and I do both lobes now. So far, I have had a few patients where the result came back with different stages between left and right lobe. So I think it's always preferred to do that, and then I would call the higher fibrosis stage, obviously. In terms of technique, I use wet suction technique. I learned this from Dr. Shang. He can speak more as well. Basically, you put about 4 cc of heparin into the syringe and then create the suction. And then I do 1 pass with 3 actuations for the left lobe, and then move into the right lobe, and then do another pass with 3 actuations.
Any significant bleeding or compared to PPG?
Definitely higher risk of bleeding because we're using a 19 gauge needle compared to 25 gauge needle. So far, I had one who had intra bleeding, and I saw it when I was withdrawing the needle after the biopsy. For that case in particular, we initially basically put down the tissue. Basically, we ignore the tissue, put it back into the tract, and then we had to use gel foam to stop the bleeding.
I think Dr. Kinkodia has a question for Dr. Chang about shear wave. Is that right?
Yeah, it was not. I know we're probably running close on time, but it was not done during this procedure. How do you incorporate it as part of your thought process in approaching these patients who are sent to you from hepatology?
Yeah, great question. If the question is whether the patient has MASH or just fatty liver, then that would require a biopsy. And so the shear wave would not influence whether or not I did the biopsy. But let's say the question is, does the patient need EUS PPG? Does the patient have possible severe fibrosis and portal hypertension? Then I may use shear wave to triage whether I go further and do EUS PPG or not. So for example, in this case, if we did shear wave elastography, and let's say it came back, a value of, 5 or 6, really pretty normal, then the likelihood of the patient having portal hypertension would be extremely low. And then that may dissuade me from doing EUS PPG. So that's, but a lot of times we do all of it. We do imaging, we do shear wave, and liver biopsy and portal pressure. The other thing that's also valuable is looking at the shear wave of the spleen, because liver stiffness can sometimes be affected by inflammation. And so an inflamed liver can be stiffer than a non-inflamed liver. But if your spleen is stiffer, that's not from inflammation, right? That's from back pressure from the splenic vein drainage. And so an elevated spleen stiffness is almost always portal hypertension. And we've done studies looking at combining the spleen and the liver shear wave, and that has a very high predictive value for predicting portal hypertension. And that's why MR elastography has some advantages to, say, FibroScan. Because, I typically will start with the right lobe to measure the shear wave, because the right lobe is more stable, there's less respiratory variability, and there's less movement within the duodenum. And typically the left lobe, and repeat the 10 measurements. So it's 10 sampling on the right lobe, 10 sampling of the left lobe. And often there is some variability between the two. They're not exactly the same. And so then, then after that, we'll go on either to liver biopsy or portal pressure measurement, depending on the situation.
I'd like to ask, in respect for time, a wrap-up or a summary question for Dr. Tsai. How would you manage this patient, given the information that we have and a BMI of 36? Would you recommend endoscopic therapy, medical therapy?
So I would basically, obviously, we know that for fatty liver, weight loss is the main therapy for fatty liver. So I usually go over like all therapies that are available for the patient, going from lifestyle modification, medical, endoscopic, and surgical. For this patient, I mean, she is a candidate for all, given the comorbidities of diabetes and class 2. So, and then go over the pros and cons, expected weight loss and cons, and kind of see what patients prefer first. And then after that, I will target the discussion to that therapy. Most of the patients who come to my clinic are interested in endoscopic weight loss procedures. So if I were to see this patient, I probably would be targeting my conversation towards ESG or endoscopic sleeve gastroplasty. And based on all the numbers we saw so far, F2 fibrosis looks like maybe grade 2 steatosis based on the pathology. She would be a candidate for ESG, no need to do extra therapy before ESG. If the patients come back, if the biopsy came back F3, F4, then they are still a candidate for ESG. But we had a study where we looked at for patients with advanced fibrosis, they are more resistant to therapy. It's harder to reverse the fibrosis stage. And then we compare people who got ESG alone versus ESG plus GLP-1. And we found that the combination therapy of ESG plus medical therapy had a better chance of reversing fibrosis stage. So I would have that conversation with the patient that because you have more advanced liver disease, combination therapy probably is the way to go. And usually we would do ESG first and then offer or add GLP within 3 to 6 months after the procedure. That tends to be the best formula to get the most weight loss and at the same time the most benefit on the liver outcomes.
Yes. This morning, Dr. Concordia said, please make sure you read her new publication before we come on to Cafe Endoscopy. I'm sorry, Dr. Sheng.
No, I was just going to say that this case, it's just an amazing opportunity for intervention because the patient already has subclinical portal hypertension with a gradient of 6, which is elevated. And if the patient had an HVPG, it would probably be normal because HVPG underestimates the portal pressure in patients with MASH and NASH. So we have a elevated portal pressure, but F2 fibrosis. And so there's a really good chance that if you do an ESG and you lose 15, 18, 20% total body weight, You come back in 6 months or a year, and the portal pressure will normalize. Your biopsy will show little to no steatosis. The inflammation will be gone, and the fibrosis will be decreased. And the patient will have essentially now a fairly normal, lifespan, whereas otherwise they were heading towards liver transplant. I cannot think of a better sweet spot to intervene than this kind of patient. It's like ideal intervention.
And do you guys feel that PPG could be one of the techniques that would allow us to sort of risk stratify? Let's say I belong to a large, to some extent, resource limited healthcare system, that maybe the PPG could have a role where allows us to risk stratify patients who need all those things that you mentioned and the other that may or may not need that.
Yeah, definitely, Sonia. So we routinely integrate endohepatology into our bariatric practice, and we have PPG in that algorithm. And the main thing that we want to risk stratify is patients with clinically significant portal hypertension, and that means when their PPG or HVPG is greater than 10. But in our algorithm, we're looking for patients with PPG greater than 12 because studies in the liver literature have shown that that is correlating with a higher risk of various. We do a PPG measurement that comes back greater than 12 millimeter mercury. We typically start patients on a non-selective beta blocker, usually carvedilol, and then titrate the dose until heart rate comes down to less than 55, and then repeat the PPG measurement again. Make sure it comes down to less than 12 before we pursue ESG for that patient.
But maybe people with a gradient of 5 or 6 are the ones that we get most sort of response. And as you
Absolutely.
said, Dr. Chang, it's a sweet spot to actually intervene, right?
Totally.
Absolutely.
Yeah, F2 is a perfect spot, and PPG in that range is so satisfying clinically to see that you can reverse them from having portal hypertension to no longer having portal hypertension and reverse the fibrosis stage, definitely.
Well, thank you very much, Dr. Kankodia. We'll go on to our next case with Dr. Palzawasi and her fellow. I'll have Dr. Natali moderate this segment.
Yeah,
Please.
thanks, guys. Very nice case. I actually have a few questions for both Ken and Sai, but I'm gonna keep those questions at the end of the session. I'm gonna have Dr. Gojkan, my colleague, present our next case. Yeah, Gojkan, can you go ahead and present? This is perfect because you guys left at ESG, right? So next case is gonna be the result after we have done some intervention for weight reduction, and we'll see what happens after the procedure has been done. Okay, go ahead, please.
Okay, good morning, everyone, again, and thank you for the warm welcome today, and thank you for the introduction. My name is Gojkan, and I'm from Sirat Hospital. I'm very glad to be presenting our bariatric cases discussion for the Endoscopy Cafe today. I'll go ahead and start with the cases. This is a case of a 68-year-old woman who presented to us due to the weight regain after bariatric surgery. She has the underlying disease of type 2 diabetes, hypertension, dyslipidemia, severe OSA, which has diagnosed since 2017, and she currently on the nasal CPAP of 12 centimeter of water. And definitely, she also has morbid obesity with BMI of 54 kilogram per square meters. So at that time, we decided to perform the laparoscopic sleeve gastrectomy in December 2014. So after bariatric surgery, she was doing very well in the first few years. As you can see from this table, that her maximum weight loss was like 32 kilograms, which achieved the goal of losing more than 50% of excess weight and more than 20% of total body weight. But unfortunately, after 4 years after bariatric surgery, she started to losing the sensation of satiation and began to regain her weight. So by 2022, she has regained 10 kilograms of weight and her excess weight loss decreased to only 38%. This is her current medication. She currently on the antihypertensive medication and anti-diabetic medication and Lipitor also. And 2 of these medication could be discontinued after bariatric surgery. This is her physical examination, which show good vital signs. She has BMI now currently 44.6 kilogram per square meters. And she has no sign of chronic liver disease and other organ system was within normal limits. This is her labs investigation, which has shown my anemia with the hemoglobin of 11.7. She has normal renal functions and liver functions, has a good control of lipid profiles, and her fasting blood sugar was 125 and her A1C was 6.3. This is her transabdominal ultrasound, which is her normal liver parenchyma. She has no cirrhosis, she has no gallstone, and we suspected a little bit of fatty infiltrations. This is a video showing the EGD after 8 years of laparoscopic sleeve gastrectomy. You can see that the line was in good position. There is no twisting. The sleeve tube was quite dilated, and we can also do the retroflexion without difficulty. So that's mean that our sleeve is quite big. So here comes to the discussion part. What do you think is the best option for managing of weight regain in these patients? So we got 4 choices over here. A is laparoscopic resizing of gastric sleeve. B is conversion to room-wide gastric bypass. C is the endoscopic sleeve gastroplasty, and the last choice is medical treatment.
And you don't have to pick any of these options. Ken and Sai, maybe we'll start with Ken. Suppose LSG with weight regain at this point, I think it's how many years out? 2014, and now it's what, 2024? So it's almost 10 years out, right? But she started to regain weight at about 8 years out. So what do we do at this point?
I guess one question first is, does she have GERD symptoms?
No, she doesn't have GERD symptoms.
Because she had an open diaphragmatic hiatus. So that does factor in. If the patient had severe GERD from a hiatal hernia and a sleeve anatomy, that may factor into what we would offer. Yeah, she's 68. I don't think I would, and no GERD. So I don't think converting her to a Roux-en-Y would be the first thing I would think of. So I would probably land on a combination of endoscopic sleeve gastroplasty and medical therapy. But I defer to the expert in the panel.
Yeah. Sai, what do you think?
Yeah, I would choose the same thing. I'm leaning towards endoscopic revision of sleeve gastrectomy, mainly because we did look into the data because we're curious. So the weight loss with endoscopic revision of sleeve gastrectomy, we get about 10% weight loss. Anatomically, you show a beautiful endoscopy that we do have room to make her sleeve body tighter. You can go along. We usually do a running suture pattern, not so much U for this one because it's very tight and it's not compliant. So U really doesn't stay well. And we can talk more about that. But so we get about 10% weight loss. So then we're curious to see like, oh, if you actually did a surgical revision, how much weight loss would you get? So when we look at that data, we found out that surgical revision, kind of like surgical re-sleeve, also got actually 9% total weight loss, at least in our institution enterprise. And then we look at conversion to Roux-en-Y gastric bypass. Our weight loss with that was about 12%. Like absolute number might be higher by 1 to 2%, but not clinically or statistically significant. But then when it comes down to SAEs or AEs, definitely conversion to gastric bypass is riskier. And the fact that we go in and endoscopically revise her sleeve first, we're not closing that window. If along the line, if they want to convert her to Roux-en-Y gastric bypass, she's still, that is still an option for her.
Even in
Great.
the absence of GERD symptoms, would you do a GERD evaluation prior to decision making?
I kind of go by symptoms, usually, rather than doing pH impedance. But definitely that will be one of my main questions as well. Because patients push more towards Roux-en-Y gastric bypass if the patient is a surgical candidate.
Mhm. I think that's a good point, very good point. And Sai had also mentioned her data in this patient population as well. So essentially, it seems like the additional weight loss, percentage of weight loss is very similar among two types of surgery and endoscopic procedure. So Coach Kon, do you want to tell them what we've done?
This patient doesn't have GERD symptom, and we also haven't got any high resolution manometry before other treatment. So what we have in this case is to put this patient again on intensive lifestyle modification, including calorie restriction and encouraging her to increase her physical activities. And we also prescribed Ozempic 1 milligram per week. That was diabetic dosage due to the reimbursement policy in Thailand that we can only prescribe Ozempic in patient with diabetic indication, and the dosage must be in line with the guideline also. So we have been putting this patient on Ozempic for like 6 months, and this patient did not lose weight despite on Ozempic for 6 months. So we decided to discontinue Ozempic as well. So what we decide in this patient is to do the revisional endoscopic sleeve gastroplasty. And I want to show you what we have done so far in this case. Okay, this is the video showing how we perform the revisional procedure. In this case, I think that up to now, there's not much evidence regarding the suturing technique for the revisional procedure after lap sleeve. So due to the limited space or the sleeve tilt, what we decide to do in this case is to do the running suture pattern, starting from the most anterior part of the greater curvature and continuing to the posterior wall. You can see that we take the first bite at the level of incisura angularis. And in this patient, we use a total of 2 sutures. We continue showing you the second suture, and each suture consisting of 2 or 3 bites only. And this is the last suture of, yeah.
Go ahead. I'm sorry. Go ahead.
Okay, this is the last suture of our revision sleeve, which consists of only 2 bites. You can see that in this procedure, we has no reinforcement suture was needed because of the limited space of our sleeve shape. So, and here is the final look of our sleeve after revisional procedure. Our sleeve look like this. So here come to the next discussion part. I want to ask you the question, what are the suturing technique of the revisional endoscopic sleeve gastroplasty so far?
Yeah, so maybe Sai had kind of mentioned that a little bit earlier before we show you what we did, and I was kind of happy to hear that you, without you knowing the case or without us talking about the case, I have to disclose to you guys that our bariatric program was supported by Sai and Chris from the Brigham, and we've been working together for the past, I've known Sai for 20 years, but we've been really working together for the past 5, 6 years, just right before COVID pandemic. And we were trained on how to do endoscopic sleep by Sai and Chris. So I'm kind of glad that we didn't do anything too weird, Sai, because I think this is a good a good time to talk about the technique a little bit when we have to do ESG after LSG or even ESG after ESG, because the space is so limited. And maybe, Sai, you can share your experience with us a little bit. We've done a few of these, and we've got some, different challenges between the cases. What's been your experience, Sai?
Yeah, thank you so much, Natalie. And before I talk about the techniques, I want to mention the reason why I did not mention GOPs earlier was because she's 68, and in the US, she would have Medicare. And right now, the Medicare policy is that they only cover dulaglutide or Trulicity for GLP-1s. They do not cover semaglutide or liraglutide. So that's kind of like out of the option when you see that age, at least in this area. But yeah, in terms of pattern for revision of sleeve gastrectomy. So far, there have been 2 papers, and hopefully we'll publish a 3rd one. And I feel like everyone reported slightly different techniques. For me personally, initially, more than 5 years ago, when I learned from Chris, we used to do U pattern and then interrupted. So very similar pattern to how we perform ESG, but for the past 2 or 3 years, we actually have changed the pattern to be more similar to yours and similar to what you just showed. So essentially, we start at the incisora, and then the first suture will be a running suture pattern. The goal is to reduce the diameter of the incisora. But instead of making it a regular running, we make it a little slanted so that the first bite will be right at the incisora, and then when you come down along the greater and then posterior wall, you move it a little more proximally. And usually that suture will be about 3 to 4 stitches and then cinch. And then the second suture will be interrupted. So 2 bites, and then you kind of start a little more proximal to the first suture, and then posterior wall. And then usually you can fit in about 4 sutures. If it's really long sleeve body, you can put in 6. That's based on my experience. But then you repeat the same thing, running, interrupted, running, interrupted. The reason why we got rid of the U pattern is because the reason why you perform a U is because you want to shorten the gastric body length. But what we saw was that with sleeve gastrectomy, with that suture, it's not strong enough to really shorten it. So when you rescope them, they usually get torn or don't stay. So we think by just focusing on reducing the diameter and then get a little bit of length reduction with that slanting technique, it might stay better. So that's the reason why we changed from a U pattern to a running pattern.
Very interesting. Anyone else, Ken or the rest of the panelists? Any comments?
Yeah, so it's interesting. I'm also, I learned from Chris and Sai from the very beginning, but I can't help myself but innovate. Once they teach me something, I go left and right and up and down, and then I call Sai, "Hey, have you ever thought about this way or this way?" And she goes, "Oh, that's a good idea," whatever, or bad idea. Anyway, I think I landed on the same thing. I stopped doing U's.
Yeah.
And and so mostly eyes, and then if the lumen is larger, maybe a reinforcing. Sometimes I play around with a neopilaris right at near the incisura to narrow that down even more. But yeah, very similar.
And not uncommonly, because we also have access to the IOP, the plication device. We also like to use that device for sleeve gastrectomy revision as well, mainly because we just feel like it's just such a non-compliant space. So we want something with a bigger suture. So if the sleeve volume allows, we also pick one or the other device.
So with plication, are you doing neopilaris in the sleeve revisions too?
Yeah, same thing.
So why not do it for suturing too?
Yeah, what would prevent you from doing
Right?
the neo pylorus with suturing? Any any
Yes, I.
yeah,
Oh,
anything
I need
sorry,
to
anyone
there
add
is
your
really
steps.
good?
something.
I need to add your steps.
Oh, there is something.
Totally. I learn every time when I talk to both of you.
Yeah, yeah. Sai is, being convinced by their students about working with the neo pylorus, but she's not convinced, Ken. We'll try it next time. Try more next time.
We need to
Not,
do
Yeah,
a
so
joint procedure together.
yeah, not till you and I can combine our data, right?
yeah, definitely.
I thought I'm part of the cohort.
Speaking of data, let's just show them what happened to this patient at Gachgon.
Okay, thank you for the interesting comments. So, this is the follow-up data of our patient after we do the revisional procedure. You can see that this patient has achieved 10% of total body weight loss after 3 months and 10.9% after 12 months. We also performed the upper GI contrast study after 3 months of doing the procedure that showed that our sleep is in good configuration with no evidence of contrast leakage. And here is the final look of our post-revisional procedure after 3 months. You can see from our video that the sleep tilt remain in good shapes with all 3 sutures still in place. Although some of them are minimal loosening here. Yeah,
Yeah, speaking of
quite result. Yeah.
yeah, speaking of sutures came undone like a few months after the procedure. You guys have experienced pretty much the same. Like, the first question is, would you rescope your patient a few months after the endoscopic sleeve, just to see? We have a protocol where we rescope the patient a few months after the procedure, just to see what the sleeve looks like, what the sutures look like. What's been your experience? Both Ken and Sai, maybe Ken,
Yeah,
did you?
initially I didn't, but then I realized that there's so much we need to learn. So now I'm routinely going back and relooking, especially when Sai's team presented on pledgets. I've been pledgeting everything in the sky. I put pledgets in everywhere. I'm a pledge maniac. So I want to see what these pledgets are doing. So I'm bringing them back.
Okay.
Yeah.
And when you rescope your patient, do you see some loosened sutures, or what's basically what
Yeah.
it does happen, right? Okay.
Yeah, I feel like especially when it comes to sleeve gastrectomy revision, I feel like that tends to happen the most from my experience compared to TOR or ESG.
Okay.
But in TOR and ESG, sometimes the suture might be gone, but the stomach has healed already. And then you get some tissue brittle. Hopefully, I heard some theories, but no one has really proved it, that maybe suture is not the only thing that predicts clinical outcome, like the fact that the sutures are there or not, because it also kind of like promotes tissue healing. And then if you get good bites, good tissue healing, hopefully that, or like the change in mechanism of gut hormones might be a better predictor of weight loss.
Sai,
Yeah, I agree.
Why do you think with prior sleeve gastrectomy, the sutures come undone more easily? Because you would think you're narrow, you have less, less distension, and it's already kind of tubularized, and you're mobilizing less tissue. You would think there's less tension and therefore less suture breaking or loosening. That's a little bit counterintuitive. Why do you think?
Right. I just feel like even when you do it physically, like everything just seems tighter in
Yeah.
general, right? Compared to when you TOR or ESG. So I feel like that might have played a role, like towards why the suture just kind of like automatically wants to fall apart, because everything is tight, like the area of the sleeve.
Even though you're going a shorter distance, but the material you're working with is already fibrosed.
Exactly. Yeah.
Yeah. Okay, good. I think we have the last slide, right? Coach
Yes.
Gon to show them. Very
Okay.
last slide.
So as Dr. Nontali has told you that we actually routinely do the follow-up EGD at 3 months and 1 year after the procedure. But unfortunately, this patient just complete her 1 year follow-up this week. And then we're going to do the follow-up EGD in the next few weeks. So here come to our last slide. This is our data regarding the outcome of revisional endoscopic sleeve gastroplasty or RSG in our hospital during 2022 to this year. We performed only 4 patients, and most of them has lost more than 5% of their total body weight loss after revisional procedure. To a patient doing very well, that she get more than 10% weight loss at 1 year after procedure. Thank you.
So yeah, so Sai, as you mentioned earlier, with redo ESG after LSG, you get about like 10 to 12%, right? So
Yeah. I was like,
yeah,
we got the
our
same
number
number
is very
here.
small. Yeah.
Yeah. It was
Well,
like
yeah.
literally like 10, 11% average. Now we have done about 110 patients for revision of sleeve gastrectomy, and the average is at that number.
Yeah. So I think this case, we just wanted to highlight a couple of things, which is number one, the endoscopic sleeve can definitely be done after laparoscopic sleeve gastrectomy. Obviously, you can do a combination therapy with medication, or you can attempt medication and lifestyle modification first. But as you know, though, with patients with a huge BMI of like approaching 40 and such, the medication alone is probably going to fail most likely. And number two is we wanted to talk about the techniques, which I'm glad to hear that both Ken and Sai kind of use a similar technique with or without playing with the neo pylorus, and we'll try to convince Sai more to play with it a little bit. Yeah, so I think for the case, anyone has additional comments or questions? Phoenix, Sonia?
But then the time would tell whether it's suturing for revision or another device would be better.
That's correct. Yeah,
Right.
the plication versus suturing.
Right, plication versus suturing. And it seems like you guys are leaning towards plication for revision or for everything,
Yeah,
or which
hopefully
one
it
is?
hopefully it comes down to the anatomy, Sonia. That will be our goal. Where
I see.
with Roux-en-Y gastric bypass, we were able to come up with an algorithm based on the pouch length and the diameter of the outlet to help you choose whether suturing or plication will give the patients more weight loss. Ideally, if once we have enough experience, hopefully we can come up with something similar for sleeve gastrectomy revision.
Sai, I have a question for you.
I have one for you too.
I'm gonna try to pull
I
out
have too.
secret. I'm gonna pull out secret information from you. So what about doing myotomy in these revisions? Do you think?
Ooh.
Do you think?
Ooh.
Ooh.
They're really hard compared to V, much harder because of
Mhm.
the angle.
Mhm.
As you know, like sleeve gastrectomy, a lot, not uncommonly, they might have sleeve stenosis. And if you do pneumatic dilation a few times, they're not responding on 35 or 40 pneumatic, then Chris has done some myotomy to help with the sleeve stenosis. And those are so challenging because the muscles usually are almost perpendicular. So it's almost impossible to do partial thickness. So it's almost full thickness. But
what if you started at the anastomosis and went towards the pylorus? Just
kind of like beyond the incisora, right?
Right.
Yeah, so that's because the heart angle is at the incisora.
yeah.
Okay, so the answer is I don't know, but I feel like we might not see the same result compared to what we do for primary purposes, because we know that sleeve gastrectomy actually makes gastric emptying faster. And when you do antromyotomy, the goal is that you want to slow gastric emptying. So you actually are working against the baseline mechanism of sleeve gastrectomy. So by theory, if that is true, it should not really augment the weight loss. While when you do antromyotomy for a primary indication, we know based on small studies that ESG delays gastric emptying. So by adding or doing antromyotomy to further delay gastric emptying, you're working on the same mechanism rather than against each other. And that's why we're seeing weight loss in a primary situation. But I think it's something to be studied. But if you go by what we know so far, it seems to be working against.
Do you think our revisional strategy is to make gastric emptying faster, especially if you add a neopilaris, or you think we're making it slower?
TBD.
That's a tough question.
I feel like we definitely need to do more studies. I've been wanting to check more gastric emptying after we do revision, just to know what mechanism we
Exactly.
caused. Mhm. Definitely.
Is,
My question for you. Oh,
go ahead, please.
we love this cafe meeting hours. So in your practice, Dr. Chang, so if you see patients with weight regain after sleeve gastrectomy with acid reflux, would you choose to revise them endoscopically and then do endoscopic anti-reflux first, rather than choosing for conversion to Roux-en-Y gastric bypass?
Yeah, so as someone who's got sleeve, now has a hiatal hernia, and then now has bad reflux, if the sleeve lumen is wide enough to do a TIF, then I would do a C-TIF, right? Reduce the hernia, fix the crura, and then put in a valve using TIF. But if the sleeve lumen is narrow and they've got a hiatal hernia and bad reflux, then it would pretty much be a laparoscopic hernia repair and then likely a gastric bypass at that point, because otherwise you have no fundus to create the fundoplication either endoluminally or laparoscopically.
Mhm. Mm.
All right, good. So, but before we close, if I could just slip a couple questions in before I let you guys go to sleep, and then we from the Thai team we'll go to work. Going back to the first case. So when you use FIB-4 score to assess that patient, you got a score of 1.4. That actually put you at a very low risk. I know you said intermediate, but if you look at 0 to 1,
I think it's 1.8, wasn't it?
oh, was it
I thought
1.8?
I,
Oh, I thought
I
it was
used
1.4.
I thought it's
1.65.
1.6. I used 1.3 as a cutoff in my clinic to order fibroscan.
Yeah. So basically you got a 1.6, and then you got a biopsy of F2, which is, I think it's the biopsy seems to read as higher fibrosis if you compare that to the FIB-4. So you can see the discordance between the non-invasive test versus the liver biopsy. That's number one. Number two, if you read the current ASLE guidelines, which just came out last year, the hepatologists are leaning more towards a non-invasive test, especially for as an indication for referral, meaning, if you don't get a FIB-4 of 2, at least at our practice here, the hepatologist won't refer these patients to us for additional workup. So my question number one is that are you experience similar practice, meaning the hepatologist? These patients go to hepatologists, at least here in our practice. So you don't really get referrals that much from the hepatologist because now they're leaning towards a non-invasive test. Do you experience the same, or what's the practices like in the US? Ken, maybe we can start with Ken.
Yeah. remember the FIB4 is just age, AST, ALT, and platelets. That's not magical, right? So it's kind of making their criteria wider and wider. It's like pancreatic cysts, they have to be 6 centimeters before you touch them. I mean, right, it's kind of arbitrary and silly to me. The For me, like with cysts, is like go in and find out what's going on and characterize it. So I think in someone with elevated liver tests who has steatosis on imaging, who's obese, I think they come to endohepatology. But I mean, obviously the gatekeepers are the hepatologists, so they have to also buy into it. But to me, I think it's silly to have an arbitrary FIB4, but that's a non-hepatologist speaking.
From
And
our
yeah,
experience, very
Mm.
similar. I mean, we try to get patients from our obesity clinic in general, and we just start looking for fatty liver and then just start recruiting them, but also try to reach out to the hepatologist. And our selling point is that studies have shown that FibroScan definitely is not reliable when it comes to patients with obesity. And most of the fatty liver patients have obesity. Sometimes you can get like a 16 kilopascal one day, the next day it drops to 8. So it means nothing. So we kind of sell it that, hey, since it's unreliable, if they're going to get some kind of therapy, you might want to risk stratify them a little better. And we got a few, I want to say 3-4 hepatologists who really believe in this, and that has been very tremendously helpful to collaborate with them to build this program. Additionally, Ken Chang and our group, they published a study together last year, I believe, right? Showing that shear wave elastography performed under EUS actually is superior to the non-invasive tests, including FibroScan. In that paper, we also look at FIB4, in particular in patients with a concomitant obesity and concomitant fatty liver. So hopefully this message will go out, and that will help us kind of like integrate endohepatology into this practice.
Plus, with
Very
the cost that is associated with all the upstream therapies, we need some form of how we're going to re-stratify these patients. And I think that is probably much more reliable and less resource intensive than whatever comes. If we're doing all the other things, we probably should choose the ones who would benefit from them most.
Totally.
Right,
And
yeah.
and we like to target F2 to F4, mainly because F4 you definitely can make a big impact, and F3, F4 they're just kind of running out of options. So you want to be aggressive and do something for them before they become truly cirrhotic or have portal hypertension.
You
Okay.
guys do our job for us. You ask all the best questions, like a panelist asking each other. That's the best. We can just sit back and relax. There's nothing to do. Did
Yeah.
I
we-
love this session so much. I think we should do it every month.
Yeah, no, I agree. And
I
Ken,
can hear
I have one last question for Ken though. This is about PPG, and it's been a question that I've been wanting to ask you. I've asked Sai this question before, and she thinks it's okay to get something like this. So when I do PPG, and I only do PPG at this point in cirrhotic patients with esophageal varices or gastric varices only, because I'm doing a multi-center study with the Hong Kong team. And what I've seen in my experience is that the absolute numbers of pressure from a left hepatic vein and portal vein that I've received, for example, it's in 2-digit range, meaning my left hepatic vein will be in the 10 range, anyway, like 10 to 13, it runs around there. And the portal pressure would be about 20, sometimes it get to 25. So my gradient is similar to others. I get a gradient of 12, 13, 15, whatever. But the absolute number is completely different. Most people would get single digit number. So my question to you, and I measure 3 times, I guess similar, within 1 to 2 millimeters apart. among those 3 times. My question is that the reason I get numbers like this is because it's a technical issue, or it is, maybe just the patient, but I've done about, 10 or 12 of these in cirrhotic patients. And this is the numbers, the absolute numbers, I'll get 2 digits every time. Is that something that
Yeah,
I
I
did
think
wrong?
a lot of it is just where you set your 0 point. So where you put the pressure gauge relative to the patient. So if you put it on the bed, you'll get a higher absolute number. If you put it in the mid clavicular line, it'll be higher. If you put it, more at the top of the chest, then that absolute number will fall to 6, 7, 8. But the gradient will be the exact same if you keep the pressure gauge at the same place consistently. So you never want to move it up and down. But where you choose to start can affect your absolute number. Does that make sense?
Yeah, I would that's what I thought so too. So I kind of move around my patients are left lateral, and I put the pressure gauge at about like mid clavicular line, but I kind of try a different different area, but in the same mid clavicular line. So
Yeah.
I get the absolute number of 2 digits always. So I
Yeah.
guess that's acceptable, right? As long as it's
It's fine. It's fine.
okay.
Yeah, if you're gonna put the patient in left lateral, I think Sai is doing mid sternum, right?
Mhm.
So then her mid sternum is higher than your mid clavicular.
Yeah.
Yeah, and that'll account for a few millimeters of mercury right there.
Okay. Okay. So
But
as
at
long
the
as
end,
it's acceptable, I think it's fine, right?
Exactly. Yeah.
at the end, we're looking at the gradient, not the absolute numbers, right?
Yeah.
Correct.
That's the,
Unless your initial number on the hepatic side is over 20,
yeah.
then
No.
then think about right-sided heart failure.
Yeah.
Right.
Yeah. But I've never reached 20 with the hepatic vein. Yeah.
Yep.
Okay. I think that's good. That's pretty much what I have to ask.
We learned so much today. We thank everyone who's on the panel, and Dr. Riker will close for us. We are missing one member. I'm sorry I didn't say before, but Dr. Mary Lee Quinsky, our third partner, she has a family emergency and was not able to join us today. Dr. Riker,
No,
closing
but
comment.
we're so grateful to all of you for being here, and to Dr. Cheng and to Dr. Repena and Nantali. Thank you for sticking with us. We finished the year, and I think we had a lot of fun doing it.
Yeah, we got to bring these 2 back.
Oh yeah, well, it seems to me like we have a lot more questions to ask.
I
and
know.
think if we
Within
just
the
leave,
group.
no, if we just leave 2 of you and we sit back, then I think you guys will take care of the whole thing. We would need to do anything else. Well, thank you so much.
I think, Christian, we can go offline, and if physicians want to discuss further, they can. Christian, we're calling it.
The day.
We're calling the day, yeah.
Yes, thank
So
you.
Beautiful.
everyone can continue conversing if you would like, otherwise the session closed.
Yeah,
Thank you
yeah.
again,
Thank you so
everyone.
much.